Okay. So I think we are going smooth. Can I get a quick thumbs up? Anybody can give me a quick thumbs up? Great, great, great. Chalo, so we'll start with the first question. I hope everybody is ready for some image-based questions in dermatology. Yes, so I can see myself now. So I think it's going smooth, and I hope everybody is fine with the audio also. So without wasting much time, I want this session to be a very useful session for everyone. So we have some images, and let us start with the first question. Good evening to all of you. Good evening, Sarika, Ashmita, Paras, Subhash, Rajat, Rishabh, and many more who are joining. So let us start very quickly with the first question. And I don't know why this is not showing up on the screen. Yes, now it is visible. So the question says that we have a patient who was treated with steroid for psoriasis. On stopping the treatment, he develops fever, malaise, and lesions as seen on the image. What is the most probable diagnosis? So now first of all, let me show you the image little bit, by zooming it. You can see a lot of pustules here, some discrete and some confluent pustules. You can see that some pustules, they are combining together to form large lake of pus. So this is a known case of psoriasis. The question itself says that the patient is a case of psoriasis. Can you think that what type of psoriasis can present with the pustular lesions on the skin? Anybody here can give me the answer? Very nice. Shreyas, Paras, Ashutosh, Arshad, Subhash, and many more students. Please remember, normally the most common variety of psoriasis, it presents with papules and plaque superimposed with silvery micaceous skin. And this variety of psoriasis is known as the chronic plaque psoriasis or psoriasis vulgaris. In majority of the patients of psoriasis, you see papule plaque and associated with silvery micaceous skin. But there are some variants of psoriasis, and one of the variant is pustular psoriasis. In pustular psoriasis patients, you develop pustules which are sterile. So you can see here there is sterile. There's no history of any bacterial infiltration. So it is a sterile pustule which can be localized, which is known as localized pustular psoriasis, or it can be generalized, which involves more than one body part. And all these pustules, they're combining together to form a lake of pus. So you can see here, this is a very classical acute generalized pustular psoriasis. And the correct answer of this question is option number 4. Now tell me one thing, what is the treatment of choice in a psoriasis patient? So let me ask you some question related to this topic. Now, can anybody tell me what is the treatment of choice for psoriasis? Do we give steroids in psoriasis normally? Systemic steroids, if I be more specific, do we give systemic steroids in a patient of psoriasis? Yes or no? The answer is no. We never give systemic steroids in a psoriasis patients. The treatment of choice for majority of the patient is methotrexate, immunosuppressive drug, or acitretin, or cyclosporin. If we have to give systemic, we never give steroids in a patient of psoriasis. In this question, this patient is ill-treated with steroid. Please remember, when you treat the patient of psoriasis with steroid, there is a tendency that a patient goes into an unstable variety. Either it will go into an erythrodermic form or it will go into an pustular variety. So this is a patient who was mistreated with steroids, and following which, on stopping this drug, he develops sudden pustular lesions. So this is your acute generalized pustular psoriasis. Clear with this question? Anybody has any confusion in this? Clear? So this was the first question. Please remember, psoriasis topic is very important. We do get a lot of questions from psoriasis. So this is your question number 1. Coming to the next question given on the screen. Now this is again a very interesting question and from a very important topic. What is the answer of the question number 2? The correct answer of this question, now let's read the question together. We have a patient who presented with flaccid bulla, which involves the oral cavity and the skin. He has lesions as shown in the picture below. You have acantholytic cells when you do a zinc smear. So, a lot of clues are given in this question. What is the most probable diagnosis? Now, first of all, look at this image. In this image, can you see here? This is a bullous lesion, and you can see erosions, you can see crusting. So, one thing which is very clear from this image, and that is it is a patient of vesiculobullous disorder. Why vesiculobullous disorder? Because you see vesicles, which are fluid-filled lesions of less than 1 centimeter, or bulla, fluid-filled lesion of more than 1 centimeter. And along with that, you have erosions and crust. Can you tell me the answer of this question? Anybody can tell me the answer of this question? You have flaccid bulla. Now, before you solve this question, I will tell you a very simple trick which usually I teach in my classes. Whenever you get a question of vesiculobullous disorder, you have to first see the type of bulla. The type of bulla can be of two types. One is flaccid or another is tense. So always look at the type of bulla. So let me just teach you in a very simple terms. Whenever you have a question of vesiculobullous disorder, first thing you will do is you will look for the type of bulla. Either it is flaccid or it is tense. Flaccid bulla indicates that we are dealing with intraepidermal split. And in intraepidermal split, we have to think of two differential diagnoses. One is pemphigus foliaceus and another is pemphigus vulgaris. So whenever you have a patient of vesiculobullous disorder with flaccid bulla, only two DDs should come into your mind more commonly or first. Now, when you get the flaccid bulla, the next thing you have to think of is the mucosal lesions. If the question says that flaccid bulla, it is associated with the mucosal lesion, this becomes a patient of pemphigus vulgaris. But if the question says that the mucosal lesions are not present, this becomes a patient of pemphigus foliaceus. So this is a very simple way to solve the question. If I take you back to my question, the question was a patient with flaccid bulla and there is associated oral cavity lesion. So now you know flaccid means intraepidermal with mucosal lesion. The answer automatically becomes pemphigus vulgaris. The second DD which should come into your mind is the tense. When it is tense bulla, it means we are dealing with subepidermal split. We are dealing with subepidermal split. In subepidermal split, the three differential diagnoses is bullous pemphigoid, pemphigoid gestationalis, and linear IgA disease. Linear IgA disease. How to differentiate between the three? In bullous pemphigoid, you get a patient who is elderly patient, which is associated with itchy bulla. In pemphigoid gestationalis, you have a pregnant female with itchy bulla. And for linear IgA disease, you have a child with itchy bulla. A child with itchy bulla. So please remember, this is a very simple trick to solve a question of vesiculobullous disorder. So anybody who is ever confused with vesiculobullous disorder chapter, try to use this table. It is very simple. Look at the type of the bulla. If it is flaccid, means intraepidermal, two DDs, foliaceous and vulgaris. If it is tense, means subepidermal, 3DDs, more commonly bullous pemphigoid, pemphigoid gestationalis, and third is linear IgA disease. Ashmita, I told you there are many more DDs of flaccid, there are many more DDs of tense, but these are the commonly asked and these are usually confusing. Why it is not dermatitis herpetiformis? Because in dermatitis herpetiformis, you get the gluten sensitive enteropathy. So they will have a completely different history. They will give you in question that a patient on taking meals have diarrhea, pain abdomen. So they will give you some history associated with DH. But these are the patients who only present with the cutaneous lesions. Can I get a thumbs up from all of you if this is clear? Okay, so we are going back to our question and I hope this is clear to all of you. The correct answer is option number 1, pemphigus vulgaris. When you do a Zhang smear, what is Zhang smear? Just listen to me very, very carefully, everyone. Now imagine there is a patient of vesiculobullous disorder and there's a bulla here. What you do, you take a scalpel blade and you remove the roof of the bulla. When we deroof the bulla, we scrape the base and whatever material is collected, we just spread it on the glass slide. After this, we put Giemsa stain. This technique is known as Zhang smear. And what does Zhang smear shows? It shows the content of the blister fluid. Which cell is floating inside the blister fluid? Please remember, in the pemphigus group of disorder, it is the acantholytic cell, the round keratinocytes which are floating inside the blister fluid. Clear? Okay, great. Now let's go to the third question. Let's go to the third question. Now tell me the answer. You can see that on the neck there are two ulcers. There is a history of nodule before the onset of ulcer. The question says that ulcer with overhanging undermined edges in the neck region, the as shown in the image, what can be the diagnosis? So anybody can tell me the answer. So we are on the third question right now. I want the answer for this question. I think this was asked in one of the entrance exam. I don't remember which exam right now, but yes, this is a PYQ. So they have not given you much history, but they have given you an image which shows the ulcers on the neck. If you want, I can zoom the image. You can see that they are not associated with much of the inflammation. They are a little bit cold in their presentation and they are present on the neck. And I think I have a lot of students who are right for this question. Very nice, Rishabh, Anamika, Rajat, Shreyansh, Navdeep, Gaurav. Very nice, all of you. The correct answer is this is tuberculoid lymph node. And can you tell me this type of tuberculosis is known as where you see the involvement of underlying lymph node and after some time there is the bursting of that lymph node on the overlying skin. This is your scrofuloderma where the skin is involved secondary to the underlying lymph node. Tubercular lymph nodes, they will rupture on the overlying skin. Now, please remember, tuberculosis of the skin, the causative agent is Mycobacterium TB. Now, I want all my students to listen to me for the next 5 minutes. I'm about to tell you a very, very important point. Now, TB of skin, you all know that usually one organism causes similar type of presentation in all the infected individuals. If, for example, if somebody develops infection with treponema, they all will have, or those who are infected with treponema, they all will present in a very similar manner. They will have the primary stage, the secondary stage, the latent, and so on. So usually one organism causes similar type of complaint in the affected individual. But that is not the case in the TB patients. Mycobacterium TB can cause different clinical lesions in different individuals. For example, in some individual, it presents with a verrucous lesion, and this is known as tuberculosis verruca cutis. In some individual, it presents as an annular plaque, and this is known as lupus vulgaris. In some, it can present like a canker, known as TB canker. Or in some individuals, they can present with the involvement of the neck skin, which is scrofuloderma. So the question is, why a single organism presents in different morphology in different individuals? This is because there are some factors which play a role. Now, everyone, please look on the screen just for 1 minute. Now, we have almost 4 types, the most common types of TB of skin. One is TB canker. Then tuberculosis verruca cutis. Then we have lupus vulgaris. Then we have scrofuloderma. So I asked you a question that why a single organism manifests with different morphology in different individuals, because there are two factors which play a very, very important role. One is the mode of entry, how the organism enter your skin, how the TB bacteria entered your skin. There are two modes. One is exogenous. The TB bacilli, it entered your skin from outside environment. For example, you were walking barefoot, you suddenly accidentally you stepped on the sputum of a TB positive patient. So, exogenous entry. A microbiologist working in the lab, suddenly there was trauma to the skin, exogenous entry. The patient was, or the microbiologist, he was working with the samples of TB and trauma to the skin, exogenous. So this is the mode of entry. The another mode is endogenous. Imagine a patient of lung TB. Suddenly the mycobacterium TB from the lung entered the blood, from the blood entered your skin, endogenous. The TB of lymph node accidentally affected your skin, endogenous. So the first factor which play a role is mode of entry, and the second factor which play a role is immunity. The CMI, cell-mediated immunity, specific to MTB bacilli. Please remember, students, the exogenous mode of entry with poor CMI, this is TB canker, and exogenous with good immunity, this is TBVC. Endogenous with good immunity, this is lupus vulgaris, and endogenous with poor immunity, this is Scrofuloderma. And that is why TB canker is a multibacillary type, TBVC is a paucibacillary, lupus vulgaris paucibacillary, and Scrofuloderma multibacillary type of TB. Understood this point? There is one exception to this rule. Lupus vulgaris is the only type which can occur due to both exogenous and endogenous. Otherwise, broadly, this table suffices all the useful features related to the skin TB. Can I get a quick thumbs up from all my students if you have understood? So, a single organism causes different type of morphology in different individual because of two factors. One is the mode of entry of the organism, and the second is the cell mediated immunity. Okay, so yes, for more detailed discussion you have to come to the eMedicoz app or DAMS Delhi, uh, because students asking me, ma'am, images and all, we do have everything there, but here the time is very limited, so I may not be able to share everything. But yes, you can just download the app and you can just go through my lectures. So I hope you have understood this, and the answer of this question is also very clear. Now let's go to the next question. I hope everybody is ready. Can I get a quick thumbs up? Okay, chalo. So which mineral deficiency can lead to the following condition? Which mineral deficiency can lead to the following condition? क्या answer होगा? What will be the answer here? Anybody? Ayush, Ashmita, Lakshmi, Buzz, Megha, Sagar, Ashmita, Siddharth. Now here, let me first zoom the image. That is more important. If you know this image, your question becomes very easy. If you concentrate this question, you can see that patient develops some lesion around the genitals and around the mouth. You can see both the images. Here, this is genitals, and the other image is around the oral cavity. So one thing which I can write here is that the patient has very classical peri-orificial lesions. I think this has given you a lot of clue. A patient with peri-orificial dermatitis, a patient with alopecia and diarrhea. This is what? This is a patient of acrodermatitis enteropathica if it is congenital, or he can be a acquired zinc deficiency patient. What is the classical triad? Can anybody tell me what is the classical triad? The mnemonic is DAD, D-A-D. So you have diarrhea, you have alopecia, and you have peri-orificial dermatitis. So this question was recently asked in, I think it was asked in FMGE exam. A little different from this one, but yes, similar question. Now please remember there are two types. One is acquired, another is congenital. The congenital zinc deficiency is known as acrodermatitis enteropathica, which is very commonly seen at the time of weaning. What is weaning? When you stop or reduce the mother's milk and when you start the patient or start the baby on the top feed, it is that time when the patient first show the symptoms of acrodermatitis, enteropathica, or zinc deficiency. Okay, so I think it's a very easy question. We are not wasting much time on this. Let us go to the next question. Are you all ready for the next question? Coming to this question. Question from a very important topic. Identify the condition shown in the image. Although it's very easy, but let's see how many of you know about this. So what is the answer? Identify the condition shown in the image: condyloma acuminata, Bowen's disease, condyloma lata, and hemorrhoids. So very nice. I think everybody knows about this. This is a very classical example of condyloma acuminata, which is nothing but the genital wart. Can you tell me, what strain of HPV? I hope you all know that this genital wart is due to human papilloma virus. Can you tell me which strain of HPV causes genital wart? Anyone? Uh, Chandani, it is not, I'm very sorry, it is not 1618, it is 611. Please remember the strain of HPV is 6 and 11, not 1618. 1618 causes cervical cancer. Here, this is a low risk HPV, which is 611. Now, let me discuss some points related to this particular topic because I've seen so many questions being asked. Now, tell me the answer of a question which was, I think, asked in the AIIMS exam, the last AIIMS exam, 2019, I guess. So, the question was, please listen to me, all of you, carefully. The question was, in a couple, the husband showed the lesions of the genital wart. The wife do not show any genital warts at the time of presentation. What is the best way to prevent the spread? Okay, I hope everybody have understood my question. Husband had the lesions, husband with condyloma acuminata, and wife do not have any lesion. Now they are asking you what is the best way to prevent the spread. The first option which was given in the question was you give the prophylactic vaccination to the female, to the wife. You give Cervarix or Gardasil to the wife to prevent the spread. Is this true or false? Is this true or false? Anyone? This is 6, not 8. This is 6, 6 and 11. So the first option given was you give the prophylactic vaccination, Gardasil or Cervarix. Is it true or false? Please remember, it is a false statement. Why we cannot give Cervarix or Gardasil for the prevention of genital wart? Because genital wart is due to HPV 6 and 11, while the vaccinations like Gardasil or Cervarix, they are against HPV 16, 18, 31, 33. So they will not provide any protection against HPV 6 and 11. Understood this point? So that was a false statement. Second option given was you give some prophylactic antiviral drugs like acyclovir. Is it true or false? The answer is false. Again false, because acyclovir has no role against the HPV infection. The third option which was given in the question was there should be a complete abstinence from the sexual intercourse. That is the right answer. Please remember, if one of the partner has condyloma acuminata, it is best not to engage in the sexual intercourse. Complete abstinence from the sexual intercourse is the only way to prevent the spread. So this was the question. It is very, very important. Okay. So please remember, this was one question which was asked. Second was the image-based question. Now the third question, they also ask you the strains of other type of HPVs. So let me just make a table for all of you. Now the table, the genital warts, the human papilloma virus, it causes warts, and there are two types of warts. One is non-genital. The first is verruca vulgaris, also known as common wart. Now they will ask you in exam what are the strains of verruca vulgaris. It is HPV 2 and 5. Next, Number 2, verruca plana, which is plain what? What are the stain? It is HPV 3 and 10. Number 3, plantar wart, the warts which are present on the undersurface of the foot. Plantar wart. The strains of HPV causing this is HPV1. Filiform or digitate wart, like a finger-like projection. This is HPV2. These are the non-genital warts, and genital wart we have just now discussed, which is also known as condyloma acuminata. This is your HPV 6 and 11. This is your low risk virus. This is your low risk virus. Okay. So the best treatment is abstinence. Yes, you're right. Absolutely right. And this is just a table which I'm showing you. Sometimes you get questions. Please remember, you should know the images of all of them. In our question, the image was for the the image is for the genital wart, which is known as condyloma acuminata. Okay. Clear? Chalo. So the answer here is option number 1. Now let's move to the next question. The next question is here. This is another image-based question. I hope you can see the image. A patient suffering from ulcerative colitis. This is something which is very important. Presents with an ulcer on the anterior leg as shown in the image. What is the answer? See, in the question which I've asked, they have only given abstinence. Now, abstinence till what time? The abstinence till the husband has that wart. Once husband get rid of the genital wart, now there's no point of having abstinence because there's no clinical lesion. Okay, so the chances of spread also, reduces or even get completely zero. Now, this is a question is a patient suffering from ulcerative colitis presented with ulcers on the anterior part of the lower limb, which is shown in the image. Look at this image. Now, you have to see this ulcer, which is very, very important. This ulcer, if you see very carefully, it shows a very classical violaceous margin. So, whenever a patient with inflammatory bowel disorder comes to you with rapidly progressing painful ulcer, it is rapidly progressing painful ulcer with a very characteristic violaceous margin. This is your pyoderma gangrenosum. Please remember, students, in ulcerative colitis patients, what happens? The neutrophil get infiltrated into the skin. And because of neutrophilic infiltration, what happens? There's a lot of inflammation on the skin, which give rise to ulcer formation. One more thing which is very characteristic here is, if you see this, this is your cribriform scarring. So these lesions, they always heal with scar. And the scar is not very uniform. It's like cribriform, net-like scar. So this is a picture which shows pyoderma gangrenosum. And this pyoderma gangrenosum, it belongs to neutrophilic dermatosis. Neutrophilic dermatosis. What is happening here? There is collection of neutrophil in the dermis. Collection of neutrophil in dermis. Or better word is in skin. You develop collection of neutrophil in both the epidermis and dermis. This is pyoderma gangrenosum. The clinical feature is given here. There is a rapidly progressing ulcer which is very painful. Now, can you tell me how to treat these patients? What should be the best treatment? This is ulcer. So, what should we give? Should we give antibiotic or we have to give something else? Because whenever you have an ulcer, you always think of infective etiology. Please remember, the pyoderma gangrenosums, they are sterile ulcers. There is no point of giving antibiotics here. No point of taking any antiseptic measure. This is because of inflammation, and that is why the treatment of choice is anti-inflammatory. In these individuals, the treatment of choice is steroids. You give systemic corticosteroids, or you give Dapsone, which is very effective against the neutrophilic inflammation. So please remember, the treatment of choice is either steroids or the Dapsone, which works very well for these patients. Now, sometimes they ask you what are the other neutrophilic dermatosis. Just some little bit of information about other neutrophilic dermatosis. First is sweet syndrome. Just remember them. Sweets syndrome. In sweet syndrome, the characteristic clinical feature is patient develop fever, which is associated with multiple painful papules and nodules. This is your sweet syndrome. Here also there is infiltration of neutrophil into the skin. There is one more important neutrophilic dermatosis which you can get in your exam is Behçet's disease or Behçet's syndrome. What is Behçet's disease? The patient presents very classically with orogenital ulcers, and these ulcers are aphthous ulcers. There is associated joint disease and there is associated ocular feature. So these are the three dermatoses which are related to the neutrophils. One is pyoderma gangrenosum, the next is sweet syndrome, and the next is Behçet's disease. Okay. Uh, Ashi, wherever any vaccination, so I think few students are asking me the question related to the last question. See, if you have any vaccination which is working against 6 and 11, then it is effective. But they have not mentioned anything related to 6 and 11. They were just mentioning the Gardasil and Cervarix. And that is why for that particular question, we are not giving the vaccination as a prophylaxis. Okay? Understood this point? Chalo. So I think we are done with neutrophilic dermatosis. And yes, you're right, Chandni, you do pathology test. Now, because one of the students have, just shared this name, I will tell you what is pathology test. Now, pathology test, it is an intradermal test which proves that the skin is hypersensitive. See, just imagine if you have so many inflammatory cells in the skin, obviously the skin is very sensitive. Just a mild trauma to the skin will give rise to formation of a papule. This is known as pathology test. This is known as pathology test. It is positive in all three of them: pyoderma gangrenosum, sweet syndrome, and Behçet's disease. Okay, ji? Done. Now let's move to the next question. Common complication associated with the condition given below. So it's a little tricky question. They have not given you the diagnosis. What should be the answer? They have not given me the diagnosis here. So can you tell me, just looking at this picture, a patient with, and looking like a child with a yellowish honey colored crust on the face, exposed area of the body, what could be the diagnosis here? Anyone? Okay, Arohi, you are partially right. What is the, what is the diagnosis? First tell me the diagnosis, then tell me the answer. Diagnosis here is, it's a very classical image of non-bullous impetigo. It's a very classical image of non-bullous impetigo. The commonest cause is streptococcus. Non-bullous impetigo. See, impetigo is a superficial bacterial infection. Please listen to me very carefully. Impetigo is a superficial bacterial infection. It is of two types. One is bullous and another is non-bullous impetigo. I think their name are self-explanatory. Bullous impetigo means they are those lesions which clinically present with bulla formation. So they have flaccid bulla. The non-bullous impetigo, they present with this type of yellowish honey-colored crust, no bulla formation. So impetigo is of two types, bullous and non-bullous. Bullous impetigo occurs exclusively due to Staphylococcus, while non-bullous occurs mainly due to Streptococcus. You can see Staphylococcus also, but it is mainly due to Streptococcus. Now, there is a Streptococcus strain M49, and this strain is known to cause post-streptococcal glomerulonephritis, which is considered to be the most frequent complication associated with non-bullous impetigo. Non-bullous impetigo. Now, Chandni, this cannot be herpes because in herpes, this specific crusting is not seen. In the patients of herpes labialis, you see vesicles. You see a lot of inflammation associated. Can you see any redness, inflammation here? No, there's no inflammation. You just see crust. So this is a very characteristic non-bullous impetigo due to streptococcus, and there is a strain M49 which is known to cause post-streptococcal glomerulonephritis. Is this clear? Can I get a quick thumbs up from all my dear students? समझ में आया? Easy है, not very confusing. One more thing, some points I want to add here. The first thing is non-bullous impetigo. We have one more name, and what is the name given to non-bullous impetigo? It is also known as Impetigo contagiosa. So sometimes they use this name. So remember Impetigo contagiosa. This is the alternate name for the non-bullous impetigo. ठीक है, चलो. So I think everybody is, everybody understood this point. Let us move to the next question without wasting time. So this is another interesting question, and I can see, I'm sure that many of you will answer this question. मैम आपने स्वीट सिंड्रोम क्यों बताया था? व्हाट इज द रीजन? अच्छा, ओके. सो a student name R is asking you why I told about sweet syndrome. Please remember, the question was a question of pyoderma gangrenosum. So pyoderma gangrenosum में you get neutrophil infiltration into the skin. Similar to pyoderma gangrenosum, there are two more conditions in which neutrophil get accumulated in the skin. And what are these conditions? First is Sweet syndrome, and second is Behçet's disease. So all these three, Behçet's, Sweet, and pyoderma gangrenosum, they are broadly classified as neutrophilic dermatosis because neutrophil get infiltrated into the skin. Okay? If you have understood, just give me a quick thumbs up. And I hope that is what you were asking me. Okay? Chalo ji. Now this is a question, I think everybody is right. This is a very classical image of hand, foot, and mouth disease. And I think you know that the causative agent for HFMD is Coxsackie A16. Now, one thing which I want my students to note here is in HFMD patients, you develop lesions in the hand, foot, mouth, even on the buttock. I think this everybody knows because this is given in the name. But what lesions? In these patients, you develop angular vesicles. See, normally the vesicles are round, but in the patients of the hand foot mouth disease, can you see these are angular vesicles? They are not round, they are oval shaped, they are angulated. This is very classical of hand foot mouth disease. Angulated vesicle. So I'll write it here. You get angular vesicles. They are not round, angulated vesicles on the sides of the finger, on the buttocks, oral cavity, or on the foot. Okay? Clear? Understood this point? So this is your Coxsackie A16 and the condition is HFMD. Now there was once a question asked and the question was, what is the treatment of choice? Can you tell me? Can you give me the answer? What is the treatment of choice? Anyone? The treatment of choice is nothing. You just wait and watch. Give conservative therapy. There's no point of giving any antiviral drug. So please remember the treatment is conservative, symptomatic. No antiviral drug is required in these individuals. Okay? Chalo. Now let's go to the next question. Child presented with fever, pleomorphic rash as shown in the image. What is the diagnosis? Now, this is again a very classical image, and you must have read, this in your microbiology classes, I'm sure. So, like more of viral infections we are discussing because they do give you questions related to the images here. Okay. So, what is the answer? Very nice. Lakshmi, Arohi, Shreyash, then Dr. Sandeepa, Piyusha, very nice. So a child with fever, and there is one clue given in the question, and that is this word, pleomorphic rash. Pleomorphic rash. Now, I'm sure that you know that there are two words. There are two words which everybody should know. One is pleomorphic, and another is polymorphic. Do you know these two words? Pleomorphic and polymorphic. Pleomorphic means the patient contains a disease or an infection where the rash is pleomorphic, means the lesions are transforming from one stage to another stage. For example, in chickenpox, first patient develops macule. That macule will form a papule. This papule will now form a vesicle. This vesicle will now form a pustule, and this pustule will have crust. So when you see that the rash is going or converting from one morphology to another morphology, this is known as pleomorphic, different stages. And what is polymorphic? Polymorphic means at one point of time, you see lesions of multiple morphology. Lesions of multiple morphology. Okay? So both these things, the pleomorphic and polymorphic nature, is very classical of chickenpox. And can you tell me what is this? This image shows. What is this image shows? Anyone? Anyone? What this image known as? This appearance is known as. I can zoom it for you. You can see some vesicles. You can see redness surrounding these vesicles. What do you call it? So we have a very dramatic name given to this. This is known as dewdrop on rose petal. Dewdrop on rose petal. You have dewdrop on the rose petal appearance. This is not umbilicated, no. So please do not get confused. This is not umbilicated. Yes, you are absolutely right that the vesicles can be umbilicated, but the word umbilicated is, we are keeping it for molluscum, because in molluscum you develop a dome-shaped papule with central umbilication. I totally agree with you that these vesicles can also have umbilication on their top, but for describing them, we never use this umbilicated word because otherwise you can get confused with molluscum. Now, students ask me, ma'am, if both of them presents with both of them presents with umbilication, how do you differentiate? Please remember, chickenpox may you have vesicles, fluid-filled lesion with umbilication. And in the molluscum contagiosum, you develop a solid raised lesions with umbilication. So that's a two different description. Okay. So now this is a question and this is the image given, which is a very classical dewdrop on the rose petal arrangement. And I think our question is also done. Chalo, now moving to the next question. This is, I think, again, a image based question. I'm very sorry. I'm coming, in front of the image. So okay, what is the answer here? A patient comes with cauliflower growth on the foot. When you did the scraping, you can see some brown color, round shaped bodies. Brown color bodies. Can anybody give me the name for these bodies? Great. Three names. Copper penny bodies. Medullary bodies. And sclerotic bodies. So please remember that the three names are used for the same thing. Copper penny bodies, medullary bodies, or sclerotic bodies, they are seen when you do the scraping in a patient of chromoblastomycosis. What is this? This is a subcutaneous fungus known as Phyllophora verrucosa. Now, when you do the scraping of these individuals or from the lesions, you can see these brown color bodies. Now, I'm asking you one more question related to not to this particular infection, but something similar. In which subcutaneous fungus you see asteroid bodies? So there is one more question which was asked in the past. Where do you see asteroid bodies? It's a feature of sporotrichosis. It's a feature of sporotrichosis, asteroid bodies. The copper penny bodies, medullary and sclerotic, they are the features of chromoblastomycosis, while asteroid bodies is a feature of sporotrichosis. Now, one more question which you get from this topic is, what is botryoomycosis? Anybody have heard of this term? This was also one of the question which was asked. Botryoomycosis. What is this? Mycosis means like mycetoma. I'm helping you. Mycosis means like mycetoma, and botryo means bunch of grape. Where did you read about bunch of grape in your microbiology classes? Anyone? Did you read anywhere something related to the bunch of grape, the appearance resembling the bunch of grape? Very nice. Please remember, it is a staphylococcus infection. Sometimes staphylococcus presents in a very similar manner like a mycetoma. They have tumorous swelling, they have discharging sinuses, and this type of mycetoma-like lesion due to staphylococcus is known as botryoomycosis. Okay, botryoomycosis. So, students are asking me treatment. देखो, if it is a fungal infection, you give antifungal. If it is a bacterial infection, you treat the patient by antibiotic. So, it's a simple treatment is simple depending upon the cause. Okay, done. Now coming to the next question. Now this is also a PYQ. I don't know if you have gone through it or not. Little older PYQ. Now you can see a patient. You can see that around the oral cavity somewhere there are some pustules. Read the question and tell me the answer. We have a man with who is 30-year-old. He presented with pustules. He has been taking treatment for acne and he took doxycycline. The acne lesions like papules and comedones subsided, but soon patient developed pustules which are unresponsive to the medication. What is the most likely diagnosis? Very nice. Now please remember all my students. Now you sometimes if you have a patient of acne and if you remember my acne classes, I tell you that in acne patient there's a role of bacteria which is Propionibacterium acne. And whenever there is a role of bacteria, you have to treat the patient by antibiotics. One of the preferred antibiotic is tetracycline group of drug, and here you give the doxycycline, which is absolutely right. But question is saying that on starting the patient on doxycycline, the acne responded, but he started developing some pustular lesions. This is a very classical question from what is known as gram-negative folliculitis. Now, what happens when you give a narrow spectrum antibiotic for a very long duration? What happens? The bacteria or the organisms which are non-responsive to that antibiotic, they start growing. And one of the example is here that when you give long doxycycline therapies in the acne patients, sometimes there is growth of some gram-negative organisms on the skin which are not responding to the doxycycline, and they will start presenting with this type of folliculitis known as gram-negative folliculitis. Okay, this is not pustular rosacea. This is not pustular acne. If it is acne, it should respond to doxycycline. And it is not perioral dermatitis because perioral dermatitis very classically occurs around or near the margin, sparing the margin but very close to it. So the answer here is gram-negative folliculitis. Simple logic. You're giving a narrow spectrum antibiotic. That antibiotic will take care of only a very limited organisms. The gram-negative organisms will not be taken care of, and these organisms will slowly start growing on the skin. So the correct answer of this question is option number 2. How to treat? Change the antibiotic, give a broad spectrum antibiotic. Usually we combine these patients on Clinda also. So you just have to give a mix and match. Try to cover a broad spectrum of organisms. Okay? So the answer of this question is option number 3. Now coming to the next question. Now this question creates a lot of confusion in the students, and that is why I thought of keeping it today. Okay? So very nice. We don't have much time left. So a patient with fever, severe joint pain comes to you. She also presented with a pigmentation on the nose. What is the most likely diagnosis? What is the answer now? See, in this question, I've seen my students getting confused in two options. One is, although here it is very easy because they have not given you fixed drug eruption, but students usually ask me, ma'am, how to differentiate this particular pigmentation of chikungunya with that of fixed drug eruption? Because here also they, give you a history that there was fever, there was joint pain, and sometimes they give you history of drug intake also. Please remember, whenever patient has a history of fever, joint pain, and after few weeks of it, there is a very classical centrofacial pigmentation which starts from the nose, can spread to the upper lip. This is your chick sign related to chikungunya fever. This was actually one of the favorite questions. Like in 2018-19, very frequently this question was asked, because it is that time when we had a chikungunya outburst. So that time it was one of the scientists from the southern part of India who noticed that after 2 to 3 weeks of chikungunya fever, patient develops a very classical rash on the nose or upper lip. So this is your very classical chick sign. Now, why this is not fixed drug eruption? Please listen to me, all of you. First of all, fixed drug eruption, the most common site is mucosa. So majority of the patient develops FD on the mucosa. But it doesn't mean that it cannot occur on the skin. That is true. Now please remember, there should be a clear-cut history that patient has taken a drug, and after taking the drug, patient develops redness followed by pigmentation. In chick sign, there is no preceding redness or pain, and that is going into pigmentation. No, that is not the history. Chick sign means just the pigmentation after the chikungunya infection. But in fixed drug eruption, the lesion will have pain to start with, redness to start with, and later on when it heals, it will give you a pigmentation. Is this clear to all of you? Can I get a quick thumbs up? So now onwards, nobody will get confused in chick sign and in fixed drug eruption. There's no confusion only. Okay, there's no confusion. Now, few students get confused with melasma. Always remember, melasma starts here. After this, it goes to the nose or the upper lip. So if you are labeling a patient to be melasma patient, it should occur on cheek also. Plus, there is no as such history of fever or joint pain preceding the melasma. Okay, understood? So I think there is no confusion. Rosacea mein there is redness, as the name says, rosacea, like a rose. So there is no such history given in this particular question. Chalo ji. So we are done with this. Now coming to the next question. I think this is a old question from FMGE. You can see this finger, the second finger of the foot shows blistering. uh, Difference between chloasma and melasma. See, chloasma is only when the pigmentation is related to pregnancy. So chloasma word, we are just keeping this word for pregnancy related pigmentation. But melasma is a more broader terminology. Melasma can be due to sunlight, can be due to OCP, can be due to hypothyroidism, so many causes. So that's the difference between melasma and chloasma. Devansh, fixed drug eruption mein mucosa is the more common site. There will be pain, redness, which occurs first, followed by pigmentation. The answer to this question is option number 3. Now, this is a little confusing question. I don't know how many of you got this question. Now, this question says that we have a tourist guide in Mount Everest. Somebody is climbing Mount Everest. What is that first thing which comes into your mind? Cold. So, whenever you are going in a colder environment, the outside environment is very cold. You know that whenever the outside temperature is very cold, you have vasoconstriction so that you can preserve the heat loss. You can prevent the heat loss. Now imagine the areas, the distal areas which are supplied by the end arteries. If there is obstruction of that particular artery, the blood supply is completely stopped. And when the blood supply completely stops, what happens? Patients start developing changes on that part. Clinically, they will have pain followed by cyanosis or followed by change in the color. Now, if the patient is exposed to such temperature for a very long duration, due to reduced supply, due to reduced oxygen, that particular part will start degenerating, will start necrosing. So this is a very classical feature of, you can call it as chilblain or frostbite. ठीक है. So chilblain or frostbite depending upon the type of the climate, whether it is cold heat or cold water. Sorry, whether it is a cold wind or cold water. So either chilblain or you get a frostbite or a trench foot. In all of them, the peripheral blood vessel constrict, reducing the blood vessel to the distal part. Now, if you have to treat these patients, now please listen to me. If you have to treat these patients, yes, so let us repeat this. Apna time apan khud laega. Yes, very nice. Okay, so what I was explaining is, so you have already vasoconstriction. If you have to treat these patients, how will you treat them? You have to give something which prevent the further vasoconstriction. Either you will give a vasodilators, or you will give a drug which prevent the further obstruction, like the drugs like aspirin, which prevent the platelet plug formation, or you will give the blood with more oxygen, hyperbaric oxygen. So please remember, the hyperbaric oxygen, the aspirin or pentoxifylline, which is a vasodilator, it is considered to be a preferred treatment modality. But phenylephrine, which is a vasoconstrictor, you will never give this drug because it will further worsen up the condition by causing more and more vasoconstriction. So please remember, the correct answer is option number 3 for this question. Can I get a quick thumbs up for this, everyone? Okay, done. So we are done with this question. Now I think only one question is left, and this everybody knows. What is the answer here? What is the answer here? Patient presented with history of severe sunburn after only a few minutes in sun. So usually when you are exposed to sun, like for half an hour, for 1 hour, nothing happens to you, right? Because you have a normal skin, you have a normal melanin. But in this patient, they are writing you that when the patient was exposed to the sun, he started developing sunburn. Can you see a lot of freckles, a lot of pigmentation on the skin, dryness on the skin, and there is changes in the skin pigmentation? What is the diagnosis? And I'm sure you know about this. This is a very classical Xeroderma pigmentosum. This is a genodermatosis where you have a gene defect. And can you tell me what is that defect which you see here? Anyone, what is that defect which you see here? You have nucleotide excision repair defect. Now I'll just take 1 minute to explain this, and then we will wind up this session. Please listen to me, all of you. Now what happens is, now normally whenever you are exposed to the sun, everyone please listen to me very, very carefully. Whenever you are exposed to the sun, due to the UV rays, there is some abnormalities which occurs in the nucleus or in the DNA of your keratinocyte. You have nucleus in the keratinocyte, and because of UV radiation, there is some damage which occurs in all of us. But we have reparative mechanism. One of these reparative mechanism is known as nucleotide excision repair mechanism. So what does it do? Whatever damage is occurring due to sunlight, these reparative mechanisms, they are taking care of it. But there are some patients where these repair processes, this repair mechanism is defective. So whatever sun damage is occurring, it is not getting repaired, and they will start accumulating, giving rise to such changes on the skin like sunburn, freckle, skin pigmentation, and skin cancer. One of the example is Xeroderma pigmentosa. In Xeroderma pigmentosa, there is freckling, there is photosensitivity, and increased skin cancer risk. So this is your last question which we did. And I hope everybody have understood why the answer is option number 1. Very characteristic image. Remember this. Freckling associated with photosensitivity is something which is very classical of Xeroderma pigmentosa. Okay? Chalo. So with this, we are done with the today's session. I request a quick thumbs up from all of you if you have understood. I request all of you to please download the eMedicoz app, or you can join DAMS Delhi for more detailed classes of all the subject. I'm Dr. Chesta Agarwal, who teach dermatology on DAMS Delhi. So for more classes from me, you can join either the online or the offline platform. ठीक है. So good night all of you.